Hello guys, welcome to the Parsons Series and this is Uveal Tract part 2. So if you remember last time we had discussed some of the beautiful concepts of the anterior uveitis and some of the sequelae, and now we had stopped at the thisis bulbi. So from here we'll be taking today. They have given you two important images and we will be discussing these images also. They are actually of the sarcoidosis and the toxoplasmosis. Now, during the course of any type of the disease of the uveal tract, the intraocular pressure may be affected. I think this is again an important concept because whenever we are actually studying about iridocyclitis, that means anterior uveitis, we are dealing with the rise in pressure, and it is a common complication also of the recurrent anterior uveitis. So definitely you will have to monitor the IOP because there could be an acute inflammatory glaucoma also. We can have the ring synecdoche leading to the glaucoma, and then we can also have the steroid induced glaucoma. So definitely we can, and we are expecting rise in intraocular pressure. All right, now more frequently a rise in tension is seen in the active stages, which is determined first by the height of the pressure in the widely dilated capillaries. And also what we are having the difficulty experienced by the sticky albuminous aqueous in escaping through the infiltration channels which are present at the angle of anterior chamber, and this is found in the hypertensive iridocyclitis. Right now what happens in the later stages, when the pupil has been bound down by blocking the flow of aqueous from the posterior to the anterior chamber, there is a iris bombé, and therefore a secondary glaucoma may also occur. Now always this is important, and I'll try to explain what happens here. See what is happening, how the iris bombé formation is taking place. Suppose this is your cornea, and normally the iris is present something like this, and we have got the ciliary body, and then we have got the lens. Okay, now you already know, we have discussed about the glaucoma also, that the aqueous humor is formed from the anterior part of the ciliary body. Which part? The pars pliccata part. It is the pars pliccata part from which this will be formed. And which part of pars pliccata? It is the ciliary processes, right? We all know this. And how many ciliary processes we have? Normal is 70 to 80 in number. Now all this aqueous humor is moving from this posterior chamber to the anterior chamber. This is posterior chamber, this is anterior chamber. It is coming in this anterior chamber, then it is passing through this angle. We all know this is your angle of anterior chamber, and then 90% is flowing through this trabecular meshwork. Right now what is happening when we have got the iris bombé formation? We have got what you called as the ring synecdoche here. So ring synecdoche means, we'll try to see in the ring synecdoche there is a closure of the adhesions of this pupillary end of the iris. So this pupillary end of the iris is coming and it is getting adhesioned on the anterior surface of the lens, something like this. So basically the area of the pupil from where the aqueous humor has to pass from the posterior chamber into the anterior chamber is blocked. Now once this area is blocked, what is happening? We will have lot of aqueous collection. We will have lot of aqueous collection, and that too behind the lens. So we have got lot of aqueous collection and that too behind the lens. So this will be pushing the iris anteriorly, and that will be called as the iris bombé formation. Let's try to see that. This is your iris here, and this is your lens, and whole of the iris will be pushed anteriorly like this. Whole of the iris will be pushed anteriorly like this. Okay, and we have got a lot of aqueous collection here also. We have got a lot of aqueous collection here also. So basically iris is touching the cornea, and that is actually called as the iris bombé formation. I hope it's very clear what is iris bombé formation. So it is the adhesion, ballooning of the iris over the cornea. So in this case, what will happen, there will be a iridocorneal contact. So basically what we are getting is a contact between the iris and cornea, and once we have a contact between this iris and cornea, there will be sudden closure. There will be sudden closure of the angle of anterior chamber. So we will have sudden closure of the angle of anterior chamber, and when we have sudden closure of the angle of anterior chamber, we will have acute congestive glaucoma. So this is how they are talking about. Then we can have secondary glaucoma also. Now once we have got this iridocorneal contact, recurrent attacks are happening. Now we can have the synechiae here also. So synechiae here are called as the peripheral anterior synechiae. These green ones are called as the peripheral anterior synechiae. I'll write it for you. This is peripheral anterior and synechiae. So see, adhesions are always named with respect to the iris. So if they are posterior synechiae, they are posterior to the iris, and if they are anterior synechiae, they are anterior to the iris. So these synechiae are actually anterior to the iris, and anterior to the iris is the cornea. So we have adhesions between the iris and cornea. Now once you have adhesions between the iris and cornea, there will be what you called as the permanent angle closure. Permanent, or if it is not permanent, then at least it's chronic. So chronic congestive glaucoma. In this way, the patient will have the chronic congestive glaucoma, and these are the important ways how the glaucoma can develop. Raised intraocular pressure can happen in a patient of uveitis. All right, so going back, I think now you have understood the iris bombé and your secondary glaucoma here. So what they are saying is that finally, if the ciliary body region becomes atrophic, interference with the secretion of the aqueous may lead to the lowering of ocular tension, and there will be a soft eye, and that will become the ominous sign. So what is happening, that initially you have got so many reasons for the increase in the intraocular pressure, but slowly and gradually there will be something which is actually called as the degeneration. So there is a atrophy of the region of the ciliary body, and we know that it is the anterior part of the ciliary body, the ciliary processes, which are responsible for the secretion of aqueous humor. So ultimately what is happening is that ciliary body fails to form more of the aqueous humor, and we will have soft eyes, soft small eye, that is called as the atrophic bulbi or the phthisis bulbi. Okay, now repeated attack of the iritis also leads to the atrophy of the iris, which assumes a dirty brown color. So why we actually have the changes in the color of the iris, why we have the changes in the structure of the iris, all these are the signs of the acute anterior uveitis. The reason is very pretty simple, because we are having repeatedly iritis. So if I am having inflammation, I'll have edema, I will have destruction of the normal architecture. That was your collarate pattern, the spokes of cycle wheel pattern, that is changing. We can have nodules, we can also have the Koipe nodules, we can have Busaka nodules there. Then we have got the changes in the color also because of the iris atrophic patches. So if you consider here, the normal color of the iris was actually dark brown, but here it is becoming the muddy brown color or the lighter brown color. The pupillary margin is also thin and frayed. Reactions are becoming diminished. Iritis is most frequently mistaken. So what are the DDs? It is mistaken for the conjunctivitis, or it could be acute glaucoma. See, iritis is a condition which is again presenting with the acute red eye, and wherever I have got this acute red eye, I can keep it as the DD. Like it could be iridocyclitis, it could be iritis, it could be conjunctivitis, it could be acute congestive glaucoma. the error of mistaking iritis for glaucoma. Now you know some of the DDs are very very dangerous because their treatment is just the opposite. So if you are considering this iritis for the acute glaucoma, it's very very serious. Particularly the two conditions are having opposite treatment. If you see the treatment in cases of the iritis or the iridocyclitis, the treatment of choice is mydriatics and cycloplegics. While in acute congestive glaucoma, you know, the worst precipitating factor of the glaucoma is the mid-dilatation of the pupil, and that is why pilocarpine, that is miotic, is the treatment of choice there. So the two things are very close in appearance as well as the presentation, but I would say that it will definitely pay you extensively if you are not able to diagnose and distinguish between this iritis and your acute congestive glaucoma. Dilatation of the pupil, which is urgently necessary in iritis, is the worst possible treatment in the acute congestive glaucoma. So as I told you. Now going back to the two pictures, though they will come later also, but let me tell you here what are these. So this one, if you see, this is your classical, what you called as your headlight in the fog appearance. We will be talking about this headlight in the fog appearance, and this headlight in the fog appearance we get in toxoplasmosis. Okay, in cases of the posterior uveitis. While if you see the first one is your sarcoidosis, and they say there are 1 and 2 hemorrhages in the vascular sheathing. So you can easily see this red one is your hemorrhage going to there. This red one is your hemorrhage. Okay, and the yellowish area that you are able to see, this is your vascular sheathing. This is your vascular sheathing, and this is a case of sarcoidosis where you can see that the snowball opacities are settling at the bottom. So this will be your snow banking. This is actually your snow banking, and snow banking ka important cause is the sarcoidosis. So two important images, one from your toxoplasmosis and one is from your sarcoidosis. All right. Now we come to the cyclitis. Now mostly both of them will go hand in hand, and usually we do not have just the iritis or just the cyclitis, we have both, that is iritis and cyclitis. So that's why it is called as the iridocyclitis. So in cyclitis, what is happening actually, we are having the exudates from the ciliary body, and they are passing into the anterior chamber directly from the part which forms the boundary of the chamber, and indirectly passing through the pupil also. So once you know you have got exudation in the ciliary body, that is called as your cyclitis. Now imagine that you are having the cyclitis, something like this. We have anterior portion of the ciliary body like this, and then we have got the posterior portion also. Now here basically we are concerned with the anterior portion. In cyclitis I am concerned about this part. So what they are saying is that either you know it is going directly into the anterior chamber, it is passing into the anterior chamber directly from the part which forms a boundary of this chamber, or it can also pass through the pupil. So either way this can go into the anterior chamber, and we have a lot of deposition of these inflammatory cells on the posterior surface of the cornea. So this will be your keratic precipitates on the back surface of the cornea, which is a prominent feature, rather I would say it's a pathognomic feature, the most salient feature. Always remember the earliest sign of the anterior uveitis. The earliest sign of the anterior uveitis is your aqueous flare, while the most important sign is your keratic precipitates. So when these exudates are actually organizing, they not only cause the total posterior synecdoche or the synecdoche, but also surround the lens and extend throughout the vitreous. Now behind the lens also they are forming a membrane. Behind the lens also they are forming a membrane, and that will be called as the cyclitic membrane. Cyclitic word is always used with reference to the ciliary body. So this is called as a cyclitic membrane. We can also have the strands of fibrous tissue in the vitreous, and they can be anchored to the retina in the various places. Even you can have the strands of the fibrous tissue here. This fibrous tissue could be present in the vitreous cavity, and that can be going back even up to the retina. And you know that whenever you have fibrous tissue, it always has the capacity to contract. So this fibrous tissue will contract, and that can actually lead to the tractional retinal detachment. So a thing which you cannot imagine otherwise, that the cyclitis can lead to the tractional detachment, is actually happening. So now you can get an indirect question that all of the following can cause the TRD except. So you have to remember it as a DD, that it is a DD of the TRD, and even cyclitis can be one of the reasons for causing the tractional RD. The exudates that organize upon the surface of the ciliary body, they are also causing the destruction of the ciliary processes. Now this is a thing which is also related with your total posterior synecdoche. What do you mean by total posterior synecdoche? Now you have already seen the ring synecdoche. Try to understand what is posterior synecdoche. Suppose this is your iris normally, and the ciliary body like this. When you have iris, ciliary body, and like this, and this was the lens. Now normally iris is something like this. Okay, now if the iris is adjacent totally on the anterior surface of the lens like this, and anterior surface of the lens, this is actually what you called as your total synecdoche. So can you see the difference between the ring synecdoche and the total synecdoche? This is your total synecdoche, and by the time you have got the total synecdoche, we have got also the destruction of the degeneration of the ciliary processes. So there will be hypotony, and there will be no production of the aqueous humor, and that is the reason why we have got only one synecdoche causing the glaucoma. That is your ring synecdoche or the annular synecdoche. Okay, so the same thing they are saying, that hence the intraocular pressure will fall here. So can you see, we can have glaucoma also, and even we can have hypotony in the acute anterior uveitis, and even may become shrunken, quadrilateral in shape owing to the pressure of the rectus muscles, because the rectus muscles, you know, they are holding the eyeball from four ends, like this, this, and this, and this. So you know, normally the aqueous humor is responsible for maintaining the shape of the eyeball. That is why it is ablit spheroid. But when there is hypotony and the fluid is not sufficient to hold the eyeball in the normal shape, then it is in normal shape due to the four muscles. Now if you see here, we have got four muscles. So this is your eyeball here. So we have got these four muscles. So they are holding at the four ends. That is why the eyeball becomes quadrilateral. So when there is a hypotony, eyeball may become quadrilateral. That is an important point, and this will be called as a phthisis bulbi, and thereafter the degenerative changes will supervene. So this was about the iritis and the cyclitis that we have tried to discuss individually, and what can be the differences and the different characteristics. Now we will be dealing with the chronic iridocyclitis. Till now you have seen the changes in the acute one. The chronic iridocyclitis deserves a special mention because of its insidiousness and the difficulty in diagnosis. Now slowly you will gradually find that this chronic iridocyclitis is very, very slow, and usually we have got some, you know, problems that we are facing. It's really challenging to diagnose it. It is extremely a chronic disease where you are having the diminution of vision with very, very few physical signs. In severe cases, there is some ciliary congestion, there could be tenderness on the pressure of the ciliary area, a deep anterior chamber, keratic precipitates, dust-like opacities in the vitreous. So these things you have already read in the acute iridocyclitis, nothing new. But the thing is that we do not have those many signs which are not very, very pronounced. So, and that too, these changes are developing very, very gradually. So we are not having a sharp contrast between the normal and this eye. So it really becomes challenging to diagnose it sometimes. The keratic precipitates, which may be the only obvious evidence of the disease, are sometimes scattered over the triangular area in the lower part of the cornea, that is called as the arch triangle. So what is this arch triangle actually? If you try to visualize, if you are having the lymphocytes or other inflammatory cells deposited on the posterior surface of the cornea, So it would be something like this, and because because of the convection currents and because of the gravity, they are deposited more in the bottom. So the triangle kind of a thing is formed. So this triangle is actually called as the Arts triangle. We have got a Arts line that is found in the trachoma, and this is called as the Arts triangle. Very clear? Okay, now this is written that it is due to the convection currents in the aqueous and the gravity of the particles towards the bottom of the anterior chamber. So both are the important reasons for it, and these are more commonly scattered irregularly over the lower part of the cornea. They require detailed, careful examination for the discovery, and their importance cannot be overestimated. The small spots sometimes coalesce, forming small plaques. So these plaques could be translucent. Then we can have a change in the color of the iris. That is important due to the atrophy. Especially if the normal eye has a brown iris, it indicates a late stage of the disease. So change in the color of the iris, especially in the chronic cases, is again an important sign that you are getting for the chronic iridocyclitis. Now the vitreous opacities. So if you are getting the opacities in the long term cases where you are having very slow changes, you may have some opacities in the vitreous. There could be wandering leukocytes, but many are coagulated fibrin. We have albuminous exudate. So same thing that we were getting in the anterior chamber in the form of aqueous cells, in the form of aqueous flare, the same we are getting in the vitreous. So that is vitreous flare and the vitreous cells. Their mobility in the vitreous shows that this gel has become fluid, and also they are mobile. So if they are mobile and vitreous was supposed to be gel like, that does not go well. So that means there is also a degeneration in the vitreous, and vitreous has been liquefied. The disease is generally very chronic, liable to exacerbations with a gradual and insidious formation of posterior synecdoche. Vision is diminished and it recovers considerably in the intervals, but each recurrent attack leaves a more permanent defect. Again, an important thing. So if there are more number of recurrent attacks, more is the disability. After many years, the eye may become finally soft and tender and enters in the condition of the phthisis bulbi. So you people are also getting many of your causes and indications of phthisis bulbi. An important and not uncommon complication is the rise of intraocular pressure in the course of the disease to constitute the clinical syndrome of the hypertensive iridocyclitic crisis of Posner and Schlossman. So this is your Posner-Schlossman syndrome. This Posner-Schlossman syndrome is also called as, actually, it is also called as the glaucomato. It is also called as glaucomatocyclitic crisis. It is also called as the glaucomatocyclitic crisis. In this condition, eye will appear normal, and periodically we can have acute or subacute recurrent attacks of the raised intraocular pressure associated with the aqueous flare and the keratic precipitates. The latter are often so few and unobtrusive as to be seen only on the careful examination. They are not very prominent. These attacks are accompanied by the diminution of vision. We have halos around the lights. We have headaches, which very much resembles the angle closure glaucoma. We are having the attack of glaucomatocyclitic crisis. So glaucomato means we have glaucoma like a condition, cyclitic. So we have inflammation in the ciliary body also. So here we have colored halos that may be a sign of your glaucoma, and the condition is probably due to accompanying trabeculitis. This is very important, that this condition is actually due to trabeculitis. Now see the difference here. See, angle closure glaucoma takes place due to the sudden closure of the angle of anterior chamber, but here it is not the sudden closure of the angle of anterior chamber, but yes, it takes place. Glaucoma is taking place here. So what is the difference? The trabecular meshwork. The trabecular meshwork, which was responsible for the passage of aqueous humor, 90% of the aqueous humor has to pass through this area. The inflammation occurs there. So it's not the angle closure glaucoma, it's actually the open angle, and the openings of the trabecular meshwork are actually blocked by the inflammatory cells. And because these inflammatory cells will be due to the cyclitis, and due to the inflammation in the trabecular meshwork, 90% of the drainage will not take place. So I can easily say that there was cyclitis first. There was first the cyclitis, This cyclitis was leading to the trabeculitis, inflammation in the trabecular meshwork, and due to this trabeculitis there was decrease in the drainage of the aqueous humor, and due to this there was a glaucoma. So that was certainly not an angle closure glaucoma, it is actually a open angle glaucoma. There is no congestion, and this is again an important thing, you do not get congestion in this kind of syndrome. We have got white eye, though the amount of intraocular pressure is very very high, but we do not get the congestion, we do not get the redness in the eye. Okay, now the diagnosis may solely depend upon the detection of one or two keratic precipitates. You can diagnose it by this, and treatment with cycloplegics such as atropine, topical corticosteroids will resolve the attack. So treatment that we are giving is according to your uveitis only. So this finishes your anterior uveitis. Now we'll quickly move towards the intermediate uveitis. This intermediate uveitis is also called as a pars planitis because inflammation is taking place in the pars plana part of the ciliary body, and also it is affecting the periphery of the choroid. So what are the clinical features actually? This is common in the children and the young adults. Females are more commonly affected. Laterality may both eyes are affected in 80% of the cases, and the onset is insidious. Now try to visualize what is happening in these conditions. If this is your cornea, this is the iris, then we have got the ciliary body, and this is the outer tunic of the eyeball. Here we are having the lens. So this is the anterior portion which is having the ciliary processes. Now this will be your posterior smooth part of the ciliary body, which is actually the pars plana parts. So if I am having the inflammation in this part, that is your pars planitis, what is happening? You will be having the vitreous humor here. So now the inflammatory cells are actually released in the vitreous humor. That is why this condition that we are having, this condition will be called as the vitritis. Now this condition is called as the vitritis, and you know, because vitreous is a gel-like structure, so inflammation in the vitreous cavity will actually lead to floaters. So this person will start having the floaters, black spots in front of the eye, and also it is affecting the periphery of the choroid. Then sometimes it is also affecting the macula, and there could be cystoid macular edema. Now whenever you know macula is involved, we can have distortion of vision, we can have metamorphopsia, and we will have the diminution of vision also. That is the reason most of the times when we have a patient of intermediate uveitis or the pars planitis, we will have floaters as well as the diminution of vision. So I think now the picture will be more clear to you. So what is happening now? It is starting with your retinal periphlebitis. It is starting with the retinal periphlebitis, means the peripheral veins of the retina are getting inflamed. So we have the leakage of the inflammatory cells into the vitreous. So this is your vitritis that I had shown you, exudation in the vitreous. The inflammation is non-specific. The patient usually presents with the floaters. This also we have discussed, and the deterioration of the vision. Deterioration of the vision can be due to the cystoid macular edema. Clinical signs includes a minimal aqueous flare with the keratic precipitates. So if you are getting the keratic precipitates, that means some amount of anterior uveitis is also present, but that is very very mild, and that is actually called as the spillover anterior uveitis. The very very mild form is called as spillover anterior uveitis, and we have anterior vitritis. And if you look at the signs, so because we are having the inflammatory cells in the vitreous cavity, suppose this is your vitreous cavity, so what will happen? The exudates will be collected, they will be forming clumps in the vitreous cavity. So we have got these clumps in the vitreous cavities. These clumps are actually called as the snowball opacities. These are called as the snowball opacities. Again, very important sign of the pars planitis. Now what happens due to the gravity? These snowball opacities will be settling at the bottom. So I showed you in cases of the sarcoidosis also that those snowball opacities were settling at the bottom, and when they are settled at the bottom, it could be something like this. They are settling at the bottom here. So then it is called as the snow banking. Then this is called as the snow banking. So snowball opacities and snow banking are again the two important signs of the pars planitis. All right. Okay, so let us read here what they are saying. They are saying that we are having the snowball exudates near the ora serrata, and they are coalescent exudates giving the appearance of snow banking. The other features include the macular edema, we have papillitis, we have disc edema, retrolenticular cyclitic membranes, vitreous hemorrhage, and rarely it could be tractional retinal detachment. So I think this whole lot is again important because they have given you a lot of things that can happen in the pars planitis, and they can ask you questions related to these clinical features. What is the DD now? Again, a very, very important thing. What are the things that you will think of when you are talking about this pars planitis? Look at the differential diagnosis here. They are talking about toxoplasmosis, peripheral toxocariasis, syphilis, multiple sclerosis, sarcoidosis. The disease could either resolve spontaneously or most of the times, 80% of the time they do not need any treatment. In the chronic cases, the therapy is disappointing, and the thing that we can give is a corticosteroids. They can be given. Immunosuppressants should be used only in the severe cases where the steroids fail. Now one thing is so a little surprising here, that they have given you toxoplasmosis in the intermediate uveitis, which is not very convincing, because in toxoplasmosis we have got the panuveitis, granulomatous panuveitis, and I think it is not very appropriate to mention the toxoplasmosis in the intermediate uveitis because it is the most common cause of posterior uveitis in India. Sarcoidosis is absolutely right here. In sarcoidosis we have granulomatous panuveitis, but snow banking and snowball opacities, that is a sign of intermediate uveitis, is quite important there. So I think sarcoidosis is good one, and we have peripheral toxocariasis, we have good syphilis, multiple sclerosis. These are all the DDs of your snow banking, but toxoplasmosis is little, okay. Now talking about the posterior uveitis. So here we are having the inflammation of the posterior uvea, and this exhibits the characteristics of those affecting the anterior part. They are exhibiting the general characteristics of those affecting the anterior part of the uveal tract. They may appear either in those form of isolated foci of inflammation, or it could be diffuse also. And if it is diffuse, what they are saying, that in the posterior uveitis, if it is diffuse, it will always go to the anterior uveitis, and that is why we tend to get the panuveitis. It is important to remember that the outer layers of the retina depend upon the choroid for the nutrition, so that an inflammation of the choroid is always involving the retina. So basically we do not have a choroiditis because inflammation of the choroid always involve the retina also, as the outer four layers of the retina depends upon the choroid for its nutrition. So we will have what you called as the chorioretinitis. That is why we will have the chorioretinitis, and most of the time when we have posterior uveitis or chorioretinitis, as they say, it could be localized, or we can have the diffuse one. So whenever it is diffuse, it is always going to the anterior uveitis also, and that is why it becomes your panuveitis, that is involving the whole of the uveal tract. Okay, now going back to the area, look at the symptoms. The typical symptoms of the posterior uveitis, it could be your floaters with or without the diminution of vision, which is often painless. But occasionally there could be pain, photophobia, and some redness can also be there if there is associated involvement of the anterior segment. So due to the anterior segment I can have redness, but otherwise I do not have redness. The signs includes inflammatory cells and opacities, that is vitritis we can have infiltration in retina, choroid, we can have edema there, we can have sheathing of vessels, then I can have disc edema, retinal hemorrhages, we can have signs of the anterior uveitis. Again, the spillover inflammation means when it is coming up from other areas, and late complication may I can have cataract, glaucoma, retinal detachment, choroidal neovascularization may occur. Now let me explain you how these kind of things can actually happening. Try to visualize, this was your cornea here, and we are having this iris, the ciliary body, and let's draw the outer part of the eyeball. This is your sclera. Now choroid I'm drawing with the red color in continuation with the ciliary body, and now I will show you the retina. So as always I will draw the retina with the blue color, and we have to start from the ora serrata here, and this is going 10 layers are going backwards, and only one layer continues to form this optic nerve. This also you know, and here I have got the lens. Okay, now if you look in the inner side, we have got the vitreous here. Now the problem is that I am having inflammation, so let us try to show the inflammation with the orange color, and I'll start with the choroidal layer, because you know it was the posterior uveitis, so it is starting with the choroidal layer here. So let us try to name this area. So this becomes your choroiditis. So this person can actually present as choroiditis. Then from this inflammation, you know that the outer layers of the retina depend upon the choroid. So it is also going to the retina. Okay, so I can have what you called as the retinitis. This patient can also present with the retinitis. From the retina, it can go to the subretinal space, it can go to this vitreous cavity also. So this person can also present with the vitritis, and in the intermediate uveitis, you have already seen that the patient of vitritis can have floaters. Patient of vitritis not only can present with floaters, he can also present with the diminution of vision due to the cystoid macular edema. Now we know that the retina actually consists of the 10 layers. So suppose these are the 10 layers of the retina. Now out of the 10 layers of the retina, only one layer continues to form the optic nerve. So this becomes the optic nerve. So from the posterior uveitis, even the inflammation can go to the optic nerve, and this patient can also present with the optic neuritis. So that is the reason why we have so much diversified presentation of posterior uveitis, and what can be the components of the posterior uveitis. I think now you have understood it. So I am having so many things here. Now look at the things. We were having the vitritis, I have told you this. Then disc edema, this will be a part of optic neuritis. Then retinitis, retinal hemorrhages we have. Then all the chronic complications of your anterior uveitis, cataract, glaucoma, RD, and choroidal neovascularization, choroiditis. Then we can also even have choroiditis. Choroiditis could be focal, multifocal, diffuse. And as with the iridocyclitis, we can have the granulomatous form. Usually we are getting the granulomatous patches of the choroiditis, usually associated with the direct organism infection. The essential feature of which will be your occurrence of accumulation of the chronic inflammatory cells, and then we can also have the non-granulomatous or exudative form. Now the one which is non-granulomatous or exudative is a non-specific plastic inflammatory response, which is predominantly leukocytes, and much exudation. The etiology is exactly comparable with the non-granulomatous iridocyclitis. So they are saying that like we were having granulomatous and non-granulomatous in the anterior uveitis, similarly we are having in the posterior uveitis also, and they can go parallelly. You can characterize the clinical features, the causes in the same manner as you were doing with the anterior uveitis. A recent focus of choroiditis, if you are seeing in a person ophthalmoscopically, it could be seen as a yellowish area, and when it's near a vessel, it is seen to lie at a level which is deeper than the vessel. Why? If it is near a vessel, you will tend to see it to lie at a level which is deeper than the vessel. Why? It is due to the infiltration of the choroid, and the presence of the exudates will be hiding the vessels. In the early stages, the membrane of the brush is intact. What is brush membrane? Brush membrane of the choroid is actually the basal lamina. So in the early stages, this basal lamina is actually intact. We do not have any problem. The only fluid can pass through it, but later what happens? This suffices to make the overlying retina cloudy, and only fluid can pass through it. Okay, but this suffices to make the overlying retina cloudy and grey, so that the edges are hazy and ill-defined. The exudates pass not only into but also through the retina, so that punctate or diffuse opacities are seen in the vitreous. Now, in the initial stages, the basal lamina of the choroid is intact, but afterwards it is actually passing through, and that is why it is making the retina look cloudy or grayish due to the collection of the exudates, and they are even, going into the vitreous. It is also leading to the vitritis. So the same sequence, remember, from choroiditis to retinitis, and from retinitis to vitritis it is going in the later stages. Now the Bruch membrane is also destroyed, allowing the leukocytes, they are passing into the retina as well as vitreous. A marked vitreous haze usually indicates a ciliary body involvement. Now if you are having a lot of vitreous haze, that means the ciliary body has been involved, while the presence of keratic precipitates on the back surface of the cornea and inconspicuous posterior synecdoche proves that in many cases of apparently localized choroiditis, the whole of the uveal tract is included. Now, as far as only the vitritis is concerned, you can always correlate it that it is started with the choroid and then it's going to the retina and the vitreous. But if you are getting the keratic precipitates, obviously if it has reached to the anterior part, you will have to consider that even the intermediate part must have been involved, and now whole of the uveal tract is involved, and therefore it's a part of the pan-uveitis. Owing to the fibroblastic activity, because of the fibroblastic activity of the choroidal stroma, the exudates will become organized, and the fibrous tissue formed destroys the normal structures. It fuses the choroid and the retina firmly together. So even what is happening, because the inflammation is found in the choroid also, and the inflammation is found in the retina also, and whenever we have inflammation, we have fibrosis. So due to these two layers are adhered together, the color of the spots gradually change to white. Why? Because there is a fibrous tissue, there is also thinning, there is atrophy. So now the color is changing to whitish in color. The pigment of RPE layer is extremely resistant, even though the cells which contain it are destroyed. Now it tends to heap up. So what is happening? The pigment which was there in the RPE layer that was very, very resistant, it is now heaping. It is heaping into the masses, both intra and extracellular, while the neighboring pigment cells are stimulated to proliferate. Isolated masses of the black pigment are thus formed in the whitish area. In the whitish area, we have got these masses of black pigment accumulated, especially at the edges, so that in atrophic stage, the white areas are surrounded by a black zone of pigment. So it is something like this. In the atrophic areas, you will have whitish areas with black areas of the pigment like this. They will be something like this because RPE layer is resistant to the atrophy. The process has then reached to its normal termination and sharply defined. Symptoms in the early stages are mainly the defects of the vision, because we are having the changes in the retina, we are also having the changes in the vitreous. Okay, symptoms are marked when the lesions are in the central area, and usually escape observation when they are in the periphery. Obviously, those lesions which are present more towards the posterior pole, more towards the central retina, are causing more diminution of vision. The inflamed area is slightly raised so that the contour of the retina is altered, causing distortion of the images and giving rise to the apparent change. So we have metamorphopsia. We also have micropsia. We have macropsia. We have got the photopsia. So these are the changes which are happening due to the changes in the retina morphology, because the image is forming on the retina. So now if you look at the macula especially, because the sharpest image of the object is formed over the macula. So what is happening, if that macula is actually elevated or it is distorted due to the edema, the images that you will see will also be distorted. So this distortion of the images is actually called as the metamorphopsia. You can see the object smaller. If you are seeing the object smaller, then this is micropsia. If you are seeing the objects larger, this is macropsia. Sometimes we can also see the flashes of the light. If you are seeing the flashes of light, this is actually again due to the irritation of the neurosensory retina, and due to the retinal irritability, we can have the photopsia. So a lot of new signs and symptoms you are seeing in the posterior uveitis that you are not seeing in the intermediate uveitis. These subjective symptoms are often accompanied by a perception of the black spot in front of the eye. This is called as the positive scotoma. Now, in the later stages, the affected areas are incapable of giving rise to a visual impulses, so that a negative scotoma are present in the field of vision. See, what is the meaning of positive scotoma and a negative scotoma? Scotoma means a blind spot. So if you are not able to see in a particular area, you have the blind spot in that area, that is your scotoma. Now normally we all have a scotoma due to the optic disc, but we are not able to appreciate it, we are not able to perceive it, so it is a negative scotoma. But what happens due to the choroiditis? If I talk about the choroiditis, so due to the choroiditis, we have a area where we are not able to have the image, because that is the area which is in front of the patch of choroiditis. So retina is not able to form the image and the patient can perceive it. So that is a positive scotoma, but they say that in the later stages the affected areas are not able to perceive those visual impulses, and therefore that will also become a negative scotoma. Central scotoma destroys the vision, and though peripheral vision still permits the patient to get about, all fine work impossible. Okay, so what is happening due to all these changes? Central vision is almost gone in these kind of patients where we have distortion of the vision and we have the positive scotoma. Peripheral vision is there, but yes, fine work could not be done by this patient. The disease is chronic, and organization of the exudates takes several weeks. The occurrence of fresh spots may extend the acute stage over a period of months, and ultimately defects becomes permanent. Usually it's bilateral. Choroiditis is classified according to the number and the location of the areas involved. So I can have diffuse choroiditis, I can have the multifocal choroiditis. So what is this choroiditis? What are the different types of choroiditis? And some other beautiful concepts of the uveitis will be taking next time. I hope you have understood what we have discussed till now. Try to revise and try to read Parsons along with us, and now I think they have given you enough time. So all those people who were having this problem, that they wanted to read the Parsons, they wanted to get an edge, and they want to learn the most important and a beautiful book of ophthalmology, the Parsons. Now we can actually afford the time. So let's meet again next week with another session of Parsons, and in case of any query or any doubt related to it, you can always message me. Thank you and happy ophthalmology.